Marilyn Bartlett, our queen, please come up to the stage. She has a really exciting panel here today and has some comments to share, additional comments to share with you. Thank you.
Thank you, and thank you, Senator Braun. Senate Bill 3548 really includes the best provisions for employer group health plans. Section 7, it's wonderful. Section 7 requires the TPA, PBM, the service provider, to provide your data to you daily. It makes you, and also they have to provide the 837 and 835 transaction sets. So you'll finally be able to reconcile what the TPA paid the hospital with what your claims run said was paid. And you're going to be able to find medical spread. You're going to be able to do a lot. And thank you, Senator Braun, for all your efforts. We thank you. Okay, panel, come up. I don't want to be up here alone. We have a great panel. We're going to talk about policy strategies, what is next. And you've heard a lot this morning on both state and federal level, and I think Shawn is the only one I'm missing. He's MIA? Okay. Well, I won't introduce him yet. To my left is Hunter Kellett. I think most of you know Hunter. He is Healthcare Director, Payer Reform of Arnold Ventures. And in this position, he oversees strategic investments to help lower healthcare spending. Prior to joining Arnold Ventures, he worked as a senior analyst on federal healthcare programs for the White House Office of Management and Budget. And then he's also worked at the state level as a legislative budget analyst for the Georgia State Senate. Hunter is going to share his insights on the policy work that's being done in various states. So his focus is going to be on the states. And we have Representative Schaibley. You all know her. I don't need to introduce her. She's just been the leader within Indiana in moving forward healthcare policy. At Mashpee, we've been able to have the benefit of being able to work directly with her and help support her efforts. She has authored and sponsored numerous bills, which she successfully helped enact into law. We're going to hear a little bit from her about her experiences actually working on legislative efforts at the state level. Chris Skisak down there. Chris is Executive Director of the Houston Business Coalition on Health, and he's also the Executive Director of the Texas Employers for Affordable Health Care, which is a legislative advocacy group. I think most of you know Chris through prior presentations here. He is going to share his experiences and perspectives about how to move policy forward at the state level as a coalition with employers, some of the challenges, and then I'm hoping he'll have time to share kind of his next endeavor. That's pretty exciting. Chris Whaley needs no introduction. You had that this morning. He's been in Indiana more than most of the Hoosiers. But Chris is a vital part, and I'm really hoping towards the end we can pick Chris's brain because I'm an avid believer that you need data to drive policy. That's the way that you can get rid of a lot of the rhetoric, and Chris is going to help us out on that. So let's kick, my slides. Oh. So we're going to cover what states are doing, what's happening at the federal level, healthcare transparency. We're going to talk about what it takes to move forward good policy, how about building a coalition and supporting good policy with data. So states are taking action. This is from the Mashpee tracker of different state policies that you can go on. And there's transparency, reference rates, competition, and other categories. And we keep up on what are the current legislative efforts, what's going on, so you can stay up to speed on that. Federal government's taking action. We talked about Senate Bill 3548 and Senator Braun's efforts. There's different policies out there to stay in touch with, and I think that your coalition leaders, I know I read a lot of the EFI messaging, really keep you up to speed on what's going on out there. And we face opposition. This came out in the Indiana Business Journal just last week, saying many Indiana hospitals struggling financially amid rising expenses. And as I shared with you this morning, you've got to kind of dig to make sure you kind of understand what's going on. I'm not saying this isn't true, but I'm just saying you have to kind of pick it apart. And I took a couple of examples. One of the things the report said is that Indiana's 170 hospitals are struggling to survive after the cost of medical supplies, drugs, laundry services, and other expenses continue to rise, while the net patient revenue per adjusted discharge decreased. So the blue line shows you that number that they're referencing. But what they forgot to add was the orange line, which is your operating cost per adjusted discharge. So that spread is the margin. So yes, that is the truth. It did decline, but you got to look at that whole picture. The data again. This is, though expenditures on contract labor have moderated since the pandemic highs, the spending remains elevated and has added to the financial challenges of hospitals and health systems. This comes from the audited financial statement. And the blue line shows you total salaries, wages, benefits for the whole entity, all of the businesses they own. This is the total. And you can see it did elevate a little bit. But you also have to start comparing this with the net patient service revenue as well as the revenue of the rest of the entities. And really, it's easy to say, boy, our direct patient care costs are up, or boy, our salaries are up. But how much are they up compared to your other revenue and your other income? So not enough of the accounting language, okay? I just bore everyone to death. We're going to hear from our panel, and I want to first start off with our latecomers. See what happens when you're late to a panel? Shawn Gremminger, I think you all know him. He is the executive director of the National Alliance for Healthcare Purchaser Coalitions, and he comes to us with a wide range of policy experience and expertise. Shawn has a history of working with advocacy for healthcare and with public affairs, with employers, plans, hospitals, consumer organizations, all working to achieve high quality, affordable, and equitable healthcare. Shawn is going to share with us his take on the policy efforts with a focus on federal and a focus on what you are doing with the National Alliance for the Fair Hospital Pricing. So Shawn, can you bring us up to speed? What's going on at the federal level?
Sure, thank you very much. Can you all hear me okay? So first lesson is don't trust the holds on your calendar. If the person who put the holds on the calendar is incompetent with time, and that's me. So my apologies. Thank you to Sarah Audi for sending me a very nice text message saying we're starting your panel. Really delighted to be here, and thank you very much to the Employers Forum of Indiana for all of their leadership. One of our more than 40 regional coalitions all over the country focused on affordability and access. And of course, thank you to Senator Braun, who's been not just a real champion, the real champion on these issues for quite a while now. We need more employers in Congress. I would say maybe fewer physicians, but that may be a somewhat controversial position, certainly in the doctor's caucus. Delighted to talk about what's going on on Capitol Hill, and the answer is quite a bit. I was a hospital lobbyist for 13 years, so apologies. But I've never seen the level of sort of activism and engagement on issues around affordability as we're seeing right now, and I think that's in large part because of the strength and the leadership by coalitions around the country, by people like Senator Braun, who's really been championing this issue, and we have quite a few others. There are some really good pieces of legislation that are actually have a chance of success in this Congress, right? As broken as it is, as much as we have a hard time seeing bipartisan bipartisan work. So the first one, that I would flag, of course, is the legislation we've already talked about, that's sponsored by Senator Braun and Senator Bernie Sanders, a rock-ribbed Republican from a red state and a Democratic socialist from Vermont. You don't see that very often on Capitol Hill. It's very exciting. It would codify what's it currently in rules around hospital and health plan price transparency. It would actually strengthen it pretty substantively, and would go farther by actually adding in clinical labs and some other fields. So, as Cynthia said earlier today, it is potentially transformative legislation, right? One of the things we hear all the time is transparency isn't enough, and the answer is transparency isn't enough. But it actually does go a long way, and it provides a foundation for everything else that we try to do on Capitol Hill. Beyond price transparency, we have been very actively supporting legislation, again, sponsored and championed by Senator Braun and Senator Tammy Baldwin from Wisconsin, another pair that don't always agree on a lot of things, but agree on this, focused on banning anti-competitive practices in the hospital field. So this comes out of actually work that we did when I was at the Purchaser Business Group on Health. We've got Randa Deaton here from PBGH, another one of our fantastic members. There's a hospital system in Northern California called Sutter Health System. Everybody, yeah. Everybody knows Sutter, I think. So they were engaging in, patently anti-competitive contracting practices. So large in Northern California that you couldn't possibly be, we were talking about what it means to be a functional monopoly, actually at lunch with Charles Miller a little bit ago. What it means to be a functional monopoly. Sutter is one in that area. We found that prices for hospital services in Northern California were 50% higher than prices for hospital services in Southern California, and the main reason was market consolidation. And what Sutter was doing was telling employers, saying, two major things. One, if you want any piece of our system, you have to contract with the entire system. And if you're an employer, you're probably familiar with this tactic. And two, you as an employer cannot negotiate for or provide differential co-payments for people to try to drive employees to lower cost or higher quality providers. So imagine you're an employer in Northern California and you say, look, I've got a pretty good network. I've kind of filled out everything I need to do, but I'm short on OBGYNs in Fresno and on musculoskeletal in Stockton and on psych in Berkeley. And so you'd say to Sutter, hey, I want to buy these pieces of what you offer. They're overpriced, but they're the only thing that's really available. I want to buy those. Sutter would say, no. Nope, you got to take everything we have, and otherwise you can't put together your network. They had a functional monopoly, right? Because you couldn't say no when you needed those pieces because they were the only game in town. So in the end, employers were paying a whole lot more. So long story short, a union sued, PBGH joined this suit on behalf of its members. Finally, Javier Becerra, then the Attorney General of California, now the Secretary of HHS, maybe the next governor of California, stepped in and said, the state is actually going to join the suit. And pretty quickly, Sutter settled, which is fantastic. And hundreds of millions of dollars were sent back to employers. But more importantly, they agreed that they would stop behaving this way, right? For a defined period, and there's like a special master or something that oversees it. I'm not a lawyer. So, not a lawyer, not a doctor. I always have to stipulate just in case I get into trouble. So we kind of said, well, if it's good enough for Sutter, it's good enough for California, it should be good enough for everybody, right? Like if we know that this is clearly illegal or clearly unethical, let's just make this a national thing. And so Senator Braun, Senator Baldwin have agreed, and so we've been trying to push on legislation that would move in that direction. There's a number of other federal policy proposals that are out there. There's a bill coming out of the House called the Lower Cost, More Transparency Act. It, in addition to working on the medical side, also does stuff on the PBM side. So I want to take a second on PBMs. The price problems that we have in hospitals are different than the ones that we have in PBMs because it's a different market, but fundamentally it's the same underlying problem, right? Very much a market that's dominated by a small set of folks. So in a hospital system, it's really about what does your local market look like, right? Because it's local. But in the prescription drug side, as you all know, 80% of prescription drugs are run through 3 large PBMs. They're highly opaque. They engage in all kinds of back-end dealing. We can talk more about PBMs if you like, but effectively just know you're overpaying significantly and you have no idea what you're paying for. So we have been working on legislation that would fundamentally reform the PBM market, provide end-to-end price transparency, so we would know, an employer would be able to have access to say, I know what you purchased this drug for from the manufacturer, and I know what other add-ons you had. And it would get rid of spread pricing, so buy low, sell high. It would mandate full rebate pass-through, so any rebates they negotiate have to go all the way to the plan sponsor. And then ultimately, you know what you paid at the back end. That would reinstate a functional market, so employers could actually have a choice and say, all right, I know what you bought it for. I know all the fees you added on, and I'm willing to pay those or not, right? I have a choice. And the big three are going to have to compete with one another and going to have to compete with the smaller competitors like Affirmed RX, who is here. They're going to have to compete with, the dozens of other small transformative PBMs that are trying to enter the market and are having a real challenge because they don't have the same market share. So we have a chance on PBM reform this year. It was close in the spring, in March. And my understanding from talking to the folks up on Capitol Hill is, in the end, they were very close on the policy. And the bill that passed in March had all kinds of other, it was a gigantic omnibus bill, and it was tied into funding for the federal government and overseas stuff. And so it got complicated. We didn't end up losing out on that because of the problems in PBMs. It was because of some of the other provisions. The last thing I want to speak to, because it's related, is ERISA. So if you're an employer, you know a lot about ERISA. If you're not an employer, you probably don't know that much about ERISA. I don't blame you. A challenge that we face kind of across the board is that states, I think, in really often well-meaning attempts, say, Congress isn't moving on something. I'm going to try to fix it myself. And I totally get it. And generally speaking, I like state innovation. I want states to be able to do more. The challenge is when they start telling self-funded plans how they have to run their business, how they actually have to structure their benefits package. That violates the federal law of ERISA. I'm not even going to try to remember. No, I was going to try to say if I could remember what ERISA stands for. I keep thinking of it, and I'm not going to get it right. So we've seen some litigation in this space over the last couple of years. Effectively, what most of the courts have decided, and there was actually a unanimous Supreme Court decision on this, is states can regulate PBMs, they can regulate hospitals, they can regulate physicians to the extent that they want to talk about sort of what they're doing within the confines of those unique entities. But as soon as a state says, oh, a self-insured or self-funded health plan, an employer, an ERISA employer, here's how you have to structure your benefits package. Here's how you have to tier PBMs or tier your network adequacy for pharmacies, et cetera. You've now violated ERISA. It's a challenge that we face because employers very strongly, self-funded employers very strongly support ERISA for understandable reasons, right? We can't be subject to 56 state and local regulations, or 50 states, 5 territories, the district. But, we don't want to, bind states from being able to be effective. So this is an area that I've spent a lot of time talking to employers about, saying, how can we help you get to policies that are going to be effective at the state level, but don't violate ERISA and don't end up having to put us in a place where we're having to sue because the state has overstepped its bounds. It's an area that I think we're going to continue to have to sort of iterate on. This is the 50th anniversary of ERISA, and we've spent some time working with Capitol Hill to try to talk about how to strengthen the legal framework while allowing for the times of market transformations that we really need to see. So it's an exciting time to be working in this space in DC. I'm super excited to be here and talk to all of you. And I think from now we're going to turn to what states can do, hopefully without violating ERISA.
Thank you. Thank you so much. Great overview. You just kind of summed up 18 months. Yeah. Yes, now we get to hear from Hunter, very active in what are states doing in this arena of lowering healthcare costs, Hunter?
Yeah, so thank you very much, Marilyn. It's been an exciting day. And as we could see from all the data here, we clearly know that hospital prices are driving a lot of the healthcare cost problem. And as Shawn just went through in the history of ERISA, states actually have a lot of authority over regulating hospitals. And so I think that creates a lot of opportunity for states to think about creative ways to get at the cost problem. Maybe it's easier to think about the cost problem from an insurance perspective, maybe because insurers are a lot less thought of or thought as highly as, the local hospital, but I really do think there is a lot of latitude here. So, a couple of things I wanted to highlight. I think it is a really interesting moment because there are a lot of parallels between what's being discussed at the federal level and what's being discussed in state capitals. And on this cost issue, we saw this on surprise billing several years ago, where state after state was coming forward and putting these protections in place, and then it really put pressure on the federal level to figure out how they were going to address it. And so, you kind of tick through all the parallels that Shawn was just talking about of the policies that are under consideration, and we can point to states that are also making progress there. So, for example, the bans on anti-competitive contracting practices, something passed in Texas last year, has been passed in Nevada as well, has been under consideration in a number of state legislatures. One thing I want to say before we kind of dive into some other examples to highlight, there's no silver bullet here. This is not a one and done situation. There's no magical regulation or policy response that is going to fix this problem. We need both, activity at the state and federal level, especially when we're talking about oversight of the insurance market here. And I think that's also good to see because we're seeing the same states coming back at it year after year. And Indiana's the perfect example. And I'll let you talk about the Indiana example. But some of the states that I want to highlight too, we're seeing each legislative session, like new approaches, new considerations, taking the feedback from industry and stakeholders like employers, and then refining those laws. At Arnold Ventures, we kind of think about it in three big buckets. So the first is transparency. And obviously we're at the National Healthcare Price Transparency Conference. Transparency is critical. It is a very, very important building block to really do anything in this space. At this point, we have over half the states have an all-payer claims database or an APCD that they either have or are implementing. States are thinking about other ways to help enforce the federal price transparency requirements, tying them to things like collecting medical debt, for example. But I think it's also worth pointing out, there's a lot of good data in the NASHB hospital cost tool, and there's a lot of good data in the RAND study. So I think a big question for states and policymakers is what more data do you need? It's pretty clear what the issue is. So we have been seeing, for example, new efforts on ownership. And as there's more and more concern with private equities entrance into healthcare, who owns this practice or who owns this hospital? And that, can tell you something. It can help piece together the story. But, like I said, there's no silver bullet here. There's no magic solution. So what we are seeing a lot of activity on this year in states is actually thinking about how they can promote competition in their marketplace, how they can have oversight of these very consolidated health systems. And I know that you probably all know this better than I do, but consolidation has gotten much more complicated. It went from you're a hospital, I'm a hospital, and now we can band together. We're a hospital system. We have more leverage for prices to you're an insurer, you're a physician practice, I'm a health system. Now I own the whole dang thing. And so, what regulatory authorities do states need so that they can have oversight of that and then also protect consumers and patients and employers and purchasers and ultimately taxpayers from the cost of that consolidated system? One model that states have been looking at is Oregon's Healthcare Market Oversight Program. So a number of states actually this past year were refining how they approved or actually even just some transparency over notifying the AG of mergers. But Oregon has authority to actually deny a merger if it's going to worsen healthcare costs, access, equity, or quality. And so that's really taking it to the next level. It's putting the onus on the entities that want to consolidate to make the case that this makes sense for their market. And I think we're going to see more and more policies like that. Another one I want to highlight, and something, another parallel is this idea of like site neutral payments, where you kind of stop paying hospital prices to physician practices that are owned by hospitals or outpatient centers owned by hospitals. Is more a Medicare policy. It's something, Shawn alluded to at the federal level, but states are also thinking about that and trying to protect consumers from things like facility fees. I think more and more legislators are hearing from constituents, hey, I used to go to this doctor's office, now it has a new name on the door, and now all of a sudden I'm getting billed this facility fee. It's several $100s on top of my physician bill, and maybe my insurance isn't covering it. And so states are doing things like transparency, but then they're also engaging in regulation, saying, hey, it's actually not appropriate for you to bill that facility fee for services that are off the hospital's main campus. Or it's not really appropriate for you to have a facility fee if it's a telehealth visit. And last year we saw Colorado consider legislation and ultimately protect consumers, but I think more to be done to protect purchasers as well from facility fees for preventative care. Like if you're really concerned about preventative care and patients are scared about these facility fees and facing medical debt, it is really a barrier for care. Just to wrap up on a couple other things I want to highlight. I talked a lot about overseeing the consolidated market, but I think states are starting to be much more aggressive. And when I look forward to next year, we're starting to see some of the pieces come into play. I think Indiana is a great example, but states are starting to pick off particular markets. State employee plans has been an area where there's been a lot of success, started by Maryland. And earlier we talked about the savings. Chris highlighted the savings Oregon has seen from their state employee plan implementing reference pricing. One other good example is the Colorado option. So it's actually a regulated private insurance plan with a premium reduction target in the state. And the way that they enforce it is they use their insurance commissioner. And the insurance commissioner says you need to save 5% next year on premiums. And if you don't do that, you have to come in front of me and explain why. And so when all the plan filings or the rate filings came in, several plans did not meet that target. And so they scheduled the hearings in front of the insurance commissioner. And shockingly, right before they had to go public and explain why they could not meet those savings targets, the hospitals and insurers reached late-breaking agreements. And I believe all the hearings were avoided. So there are a lot of different ways you can think about piecing together authorities across the whole state government, both at the state and then also at the federal level, to help put pressure on prices. Thank you.
Thank you, Hunter. Wow, a lot going on and topics that maybe a lot of us don't know. And Colorado has launched their review, and the insurance rates have been submitted, and they're now analyzing them and waiting for the other side. So it'll be interesting to see this year what happens. Representative Schaibley, boy, you have really, how can I say?
Marilyn.
You have really kicked it.
You have been amazing, and you've been a great resource for all of us here. So I want to
Thank you. It's a pleasure working with you. I know, speaking for Maureen and myself, we've worked with you quite a bit and have learned so much. But tell us about some of the Indiana work and your experiences and how you were able to move legislation forward. Tell me about this.
Sometimes it's kind of hard. But this year we've had. I'll start with last year. Last year we had 1004, which is a very big bill that we had and passed, and I was the author of. I was very lucky to carry that bill. It was when I was asked to carry it, and I'm looking at it, and it's got all these really wonderful things in, and it's like my heaven, because it had just so many things that I've been working on since I've been down at the State House. One of the things that it had was it had the price hospital oversight price task force. And that task force met last summer. And through those meetings, there was some legislation that was recommended, and we brought forward this year. And one of them was, the recommendation was, and we were talking a lot about consolidation, and it was that if two healthcare entities are going to merge and that merger is over $10 million, they, within 90 days, they have to report to the AG's office. And then the AG's office looks at it from the point of it being a being antitrust. And so that was really good. The thing is, in Indiana, we are so consolidated at this point. I don't know how much that's going to help, but hopefully it will stop the bleeding going forward. Another part of that, another recommendation from them went into House Bill 1327, which I carried, and this is the auditing, which is what you're talking about today. And it was really giving unfettered auditing to PBMs and TPAs for employers. And that, it also said you had to do it for, without a charge. And that got derailed in the Senate for me. Got held up there. However, Dr. Barrett, who he was here, I don't know if he's still here, who is the chairman of the Public Health Committee, picked that section up and put it in a bill so that it eventually passed, which I was forever grateful for. So there are often little missteps that happen when you're working something through the House and the Senate, trying to get it through the legislation. And you have to be able to be flexible and figure out, how, if A and B isn't working, how do you get it across the finish line? And sometimes it's C, sometimes it's D, as far as getting something passed. You have to, one thing that's been very important down at the State House is having the data from NASHB, having the data from the RAND report. We're very data driven. And frankly, I think the first RAND report that came out, we invited, we had a presentation and invited all of the, bipartisan, invited all of the reps and the senators to come to listen to that report. And I think that was really kind of the groundbreaking start of the things that we are doing and have been able to accomplish in the state, because people started to realize, yes, this is a problem. I mean, reps and senators, we have so many things that we deal with. A lot of it's, just general things with our constituency and small, just things that are not as big and complicated as healthcare. And so it's often very hard for a rep or senator to get their head wrapped around these issues. So that I thought was incredibly helpful. And in just educating people. All of these things, like when you try to explain to someone about anti-competitive contract, that are in contracts, it's very complicated. It's hard to explain that to somebody and explain the impact that has. So there needs to be a lot of education in this area, and I'm very grateful for the Employers Forum for what they've done, and NASHB and Gloria, and it really wouldn't happen with with all of that support. And my colleagues, I've got some wonderful colleagues down at the State House who are supportive. As I said, Dr. Barrett, who picked this bill up to get it across the line this year. Just, a lot of the people that I've worked with that have understood how important this is, how difficult it is, and how hard it is, for the public and employers to, kind of survive in this market when the cost of everything has just gotten to be so outrageous. And so, it's unsustainable now, and I keep telling people it's unsustainable. We're going to end up being in single payer if we don't start doing something about it and being really aggressive with it. I appreciate all the people I've worked with. I appreciate my colleagues who have supported the things that I've done and that they've done. I mean, a lot of the people down there have taken up the cause that we really do need to make some changes at the State House.
One of the things that I found really interesting in talking with you about was how you ever started going down this path. And it has to do with price transparency, which we have been talking about. And I really wish you would share that story with the group.
Okay. Well, this was many years ago, and it was actually before I was a rep. I was having a MRI done every year. It was just they were monitoring something and, watching. And so, I'd gone every year and had it done. The bill was $3,600. Okay, when I had it done, I went to a hospital to have it done wherever the doctor had just, prescribed it. And one year I get a call from my insurer and they say, we're not telling you where you have to go. You can go anywhere you want, but we just wanted to let you know that you can get this done close to you for us at a significant savings. And they gave me the name of the place where I could go and have it done. Well, I thought, okay, I'll check this out, because we were 80-20. I was paying 20% of that. It was a lot of money every year. And so I called up it was CDI, and I think that's changed now. I called up CDI and said, hey, I gave him the codes. I'd gotten the codes from the doctor, and told them my insurance. And within probably 3 or 4 minutes, they came back on and said, yeah, that will be $800 total. So big difference, $3,600 and $800. So I'm thinking, wow, I kind of am interested in this. So I decided, well, maybe the hospital, maybe there's just been some, really big changes, and all of this is like a big sale on MRIs or something. So I call the hospital, and they tell me, we can't tell you that. There's no way we can tell you that. We don't have that information. Well, that's kind of like waving a red flag in front of me. I don't take no for an answer very easily. So it took me about 6 phone calls to finally get to somebody who told me, yeah, it's $3,800, okay, for your insurance. So I'm thinking, okay, well, one other thing I want to do, call my doctor to make sure that the CDI, did good work, and he's, the quality is good. So I call him up and I say, ask him. I tell him what happened. He was upset that my insurer had called me because it kind of got in between the doctor, insurer, or the doctor-patient thing. But he was more upset at the price difference that he was not aware of, and that he had been sending his patients to the hospital. And he said, some of my patients are struggling, and this is, hard. So that kind of didn't sit well with me. And when I got down to the State House, not the first year I was there, but the second year I was there, I had a healthcare price transparency bill. And I will want to tell you that Representative Braun at the time was my co-author on that bill. We didn't get a hearing. It took me about 2 or 3 years to actually get a hearing. He wouldn't give me a vote, but I got a hearing. And it finally, I think it was like 3 years ago, we got it passed. So it sometimes takes a while, but when you're right, you just got to keep pushing forward. And it was an interesting experience.
I just love that story because it showed you the power of price transparency, that it started there. And then she didn't let it go. She just continued. I think the other thing that story taught me is that the first time bringing legislation up, don't get discouraged. You got to keep at it, and a lot of education is needed. Chris Whaley, I'm going to jump to you next, because you, I think one thing I clearly heard here, and I really liked your comment, Hunter, when is enough data enough? We've got a lot of data out there. We've got a lot of information about how to get the data, what the data can do. So, Chris, could you talk a little bit about what you've seen or what you recommend about good data driving good policy?
Yeah. So I guess the way I think of policies is that it's a way of making some complex and, frankly, some not so complex decisions and weighing trade-offs. In order to do that effectively, we need to have good data. And I think there are really three areas where we have to improve on healthcare data right now. So the first is employers. So if you are a self-funded employer, not to be a broken record, you're in the healthcare business and you have a fiduciary obligation to spend money wisely. One of the, I think, unfortunate things, and I cover this a little bit today, is that many employers just have trouble getting access to their own data. And so even though you're relying on a third-party administrator to process your claims, you're the one at the end of the day who has the fiduciary obligation to make sure that those payments are being done effectively and prices are being negotiated efficiently on your behalf. You have trouble getting access to data to actually make sure that that's the case. And from a 30,000 foot view, that's the entire point of doing this line of work is that employers had no idea on how much they're paying and prices that are being negotiated on their behalf. I don't think any employer here would ask a research organization to say, tell me how much am I spending on labor or what have you, because that's something that they actually have lots of insight into. And for an employer, claims data is the kind of the underlying chassis that you need to have access to. And whether that's you yourself analyzing the data, which if you're a growing employer, maybe having that capability is actually important, or a agency working on your behalf. I think one of the benefits of employers having ownership of their claims data is that they can also work with entrepreneurs to design new benefit designs, work on innovative ways to design networks and payment policies. And I think that's a kind of growing frontier where we're hopefully going to have access to a lot more data and really show the fruits of data. The second area where I think data is really important is at the state level. And so I think state all-payer claims databases are a fantastic resource and echo a lot of what Hunter said. But I think they also need to be designed in a way that actually makes them useful. So one example is the state of Florida. One of the, and building on some of Shawn's comments, APCDs run at the state level, don't have access to ERISA regulated plans. What the state of Florida did is they said, if you want to just even bid on the state of Florida public employee plan, you have to agree to submit all of your data, including your ERISA data, to the state APCD. And so it's probably the most robust APCD in the entire country. However, if you're going to access the APCD in the state of Florida, you can have either information on prices or information on providers. And so not being able to combine both price and provider level information to actually say something about how prices vary really limits the effectiveness of APCDs. And then finally, the third point is really, and again, building on what Hunter said, we need to have better data on just the complex landscape of many of these sprawling healthcare systems. And so whether it's the Parkview ownership report that Marilyn presented earlier today, I'm sure if you were to do any large system, you would get the same complex structure. But then also a lot of the emerging areas where we see a lot of financialization and investment in healthcare. So whether that's, if we look at private equity, so most information on private equity acquisitions and transactions aren't actually reported anywhere, including to Medicare. The kind of little bits of information that we learn about private equity mainly come from press releases. And so if we're thinking about, a $2 trillion economy and thinking about how to kind of deal with this emerging form of consolidation, relying on press releases isn't anywhere near sufficient. And then just a related point, we do see emerging trend of payers actually acquiring providers, and I think that's a new area where we just don't really have a great sense of how this is going to impact the healthcare system. But many of these transactions are designed, I think, fairly purposely to be at arm's length and fairly opaque. So, for example, United Health says to its investors, we employ or manage 90,000 physicians. If we look at the confidential data that providers have to report to CMS on who they work for, we see around 5,000 or 6,000. And so the complex landscape of the healthcare system and how it's evolving is totally shrouded. And we have good data on prices, can't actually monitor the system unless we have much better data on ownership.
Great. Data on ownership. I agree. Just doing an organizational chart takes days, so this is great. Chris Skisak, you have really done some things down there in Texas with your employer group, and we mentioned that you moved forward in Texas anti-competitive contracting legislation. You've been mobilizing your group, and I think if you could talk to us a little bit about the efforts to move that legislation forward, and then you had shared with me some issues around then how do you monitor it, and then talk about coalition building. How do we pull people together, employers and forums, to be a voice?
That is the a great question, the $60,000 question. Just out of curiosity, how many in this room think employer engagement in this issue is the most difficult challenge? The rest of you, gosh, I salute. I just find that to be the biggest lift, is getting employers engaged. And just by way of background, I'm a health scientist by training. Received my master's and doctorate from UT, but I wound up working for large energy companies. And what I found, there just wasn't never an appetite to understand the health investment portfolio from a value perspective. I mean, recruitment, retention, so on and so forth. But that was extremely difficult. So for the last decade, I've been leading the Houston Business Coalition on health. Employer focus, but multi-stakeholder, focusing on the triple aim. Realizing that you can't put the genie back in the bottle, there had to be some legislative advocacy. So we were fortunate to have been able to create Texas Employers for Affordable Health Care. And our first initiative, or our first bill, was House Bill 711, Texas House Bill 711, which prohibits anti-competitive language in contracts between hospitals and health plans. It had widespread support. We were able to meet with a lot of legislators. We had a dashboard, which, to Chris's point, is really important. We used the NASHB data. If you go onto this dashboard, it has the break-even, the payer mix, the operating profit margin, so on and so forth. It was very helpful to also include the local senators or representatives in case folks were interested in, and we used that to move this forward. And I say this because it is still extremely difficult. It passed the House 146-0. That never happens, right? But then we had opposition to even having it go to the Senate floor for a vote, because an influential person in the hospital system side of things didn't want it to. And we just had to happen to have an employer who had a personal relationship with the governor, and it went. It passed the Senate 30-1. Okay, 146-0, 30-1. The governor didn't sign it. It went into law de facto because it wasn't vetoed in X number of times. I say that because it's really difficult. And what makes it really difficult is because employers are not voicing their concern that this is of value. And any state, if we could figure out how to get those employers engaged, we'd be much better off. So we tried to work with employers from Dallas and Austin and San Antonio and Houston. We were just asking them to put their logos on our website to say they support it. It was next to impossible for any employer to even say, gosh, we think something needs to be done. You don't have to say a word. Just put your logo out there. Shawn knows this. We're struggling with that on a national basis. And I wish I had the answer as to how this is and can be done. That said and done, we were successful. So we got House Bill 711. Employers have no clue as to how to take this and operationalize it to their benefit. So what we hope to do to build on the coalition this year is to kind of go around the state. In fact, we're going to work with some folks in this room to try to help message that for us. Here's what you can do, and here's why it's important to us. We want to understand this, and I'm going to be here the rest of the day. If somebody can fill us in to shortcut this, we'd love it. But we are going to be doing interviews with CEOs of companies. What is your awareness of this? Do you care? Why are you not engaged? What are your obstacles to getting involved? Because if the largest funder of the healthcare delivery system in the United States, the employer, won't speak up, I don't know the answer. So we intend on doing these interviews. We're developing a survey that we can send around the state. We started a newsletter which takes all of the good work that's being done around the country by many of the people in this room, trying to get that out there. We're trying to work this through LinkedIn. We're scheduling meetings with chambers of commerce around the state. And in that regard, all we're trying to do is neutralize the hospital systems because they provide a lot of the financial support for these chambers. But we hope to be able to engage public employers, governmental and .edus, mid-size employers. I work for some of the largest energy companies in the world. They will be Malcolm Gladwell's laggards. They will be the last to put focus on this. I wish that wasn't the case because they could have so much influence. Over the course of my career, I developed and I said I'll write a book about this, my aha moments. And especially in large organizations where there's total disregard for the health investment portfolio and how the different pieces connect together. And when I left one large company, I worked with a couple other physicians, and we were going to connect the dots of this health investment portfolio. I went to employers. This is great. I love this. Let me talk to my consultant. That's where a lot of good ideas go to die. And part of the problem is that the employer, and I can't remember the speaker who said it, staff up. Mark Cuban and Gloria was talking. But there needs to be more internal expertise. I am convinced this is not an HR function. It does not belong in HR. But unless we can get the top of the food chain to say we care about this and to make that argument, it's going to be difficult. So I wish I could say, Gloria, that I've got, here's what we're doing. We've got everybody going gangbusters. We're not giving it up, but we've got to continue messaging this. As an example, Cynthia Fisher is going to carry the mantle in Houston next week for us, and she's going to be one of our next week. Sorry, I didn't mean to freak you out there. Next month, June 26th is what it is. But we've got to find a way to get this elevated at a higher level. And you know who to work? You know who's really cares about this? Is small businesses. And I don't know how many of you work with. I know Cynthia does and others. But we have found such a great partnership with Small Business for America's Future, or working with NFIB, National Federation for Independent Businesses. Those are the people who care about this. They may not be able to even provide insurance. That's a barrier. But most of those are not self-funded employers. Those are the ones that can really drive that change. And so we hope this year to have a lot more engagement by those tactics. We're going around the state, making this a show, taking some of this data, taking some of the new data that Chris shared with us earlier. So hopefully that provides a little bit of insight, maybe not answers, but it's more of a challenge than anything else.
Wonderful insight, and I really appreciate you being direct on this because I think we're all experiencing this in trying to get employers engaged. What about, do any of you want to, I saw a lot of head nodding, any comments you want to make on that? Because I agree with what Chris said. Getting the employers engaged is formidable, even getting them engaged in the federal issues or the state issues. But I haven't figured out that hook. Does anybody have a comment? Shawn?
We got two stereo.
I'll go really quick. It's clearly a gigantic challenge, and one that every one of our coalitions faces. My experience so far at the National Alliance, and we have some employers that we work with as part of what we call our National Purchaser Leadership Council, employers that are affiliated with our coalitions that work with the National Alliance. The three groups that are most engaged are unions. I'm looking at Cora. Public purchasers, states, counties, cities, and mid-sized businesses. And it's frustrating that like the people that we want are like the Fortune 500, right? The big name companies where it's like Coca-Cola says X. That's been the hardest part. But mid-sized employers have been willing to speak out. If you think about it, when getting to a place of like being able to say something publicly, if you're in a large employer, before you can do that, you've got to talk to the CHRO, and then you got to talk to legal, and then you got to talk to public affairs, and you got to talk to government affairs, and somebody's going to say no. If you're a mid-sized employer, you're like, you just call the CEO, and you're like, I want to do this thing, and they're going to be like, yeah, let's do it, go, man, So it's really helpful, I think, actually, to work with sort of mid-sized and smaller employers because there's just less layers of people who are going to tell you no. And they get real credit to our labor partners who have been, I think, really good advocates. Obviously, 32BJ is a leader, but there's plenty of others. And interestingly, sort of the public employers, which you would think have all kinds of political challenges as to why it would be hard to speak out. But for whatever reason, I give a lot of credit to a lot of the public purchasers as being willing to sort of stand up and say, like, I think maybe it's like, this is freaking state taxpayer money. Do we want most of our taxpayer money going to IU Health? Excuse me. But we love IU. But it's funny because it's actually sort of a circle, right? It's like taxpayer money going into IU to employees who then go back to IU. Anyway, yeah.
Great. And Chris, Whaley, I think you had some comments.
So just to build on that, I mean, maybe we're asking slightly a wrong question. It is not the employer's money that's going to healthcare. It is the employees. And so maybe the question is not when will HR people who don't like rocking any boats face pressure from their own workforce, and maybe that needs to be some dimension of the messaging. And then, yeah, good. Well, and by the same metric, Johnson & Johnson is not a small or medium-sized company; they're a very large company, and that ability or need to do something about healthcare costs is becoming real for them.
Okay. I'm not good with mics. What I want to say is, in Indiana, we did have this year. We had a reference-based price bill, and for the state health plan, and I want to say the people at the state health plan were absolutely wonderful. I mean, they were behind it, 100%. Really very knowledgeable on the subject. They had really worked it. Representative McGuire carried that bill. It didn't get through, but I'm hoping that it'll come back again next year. And I want to reiterate that if we can pass all the legislation in the world, but if the employers don't really roll up their sleeves and use it, it's kind of frustrating.
Well said. Chris
Can
Skisak.
I comment on that in just a minute? Because she's sitting right here. I don't know how many of you follow Relentless Health Values. Stacy Richter, anybody? I mean, she is like the best healthcare podcast in the world, in my opinion. And there was one, I can't remember the episode, but it featured Lauren Villa. And Lauren talked about the 5 reasons for employer inertia, and you know, why should the employer be responsible for fixing this mess? You know, I think that was one. Number 2 was the over reliance on consultants. We addressed that. There's no internal expertise. I don't know how we elevate that to where, hey, we need somebody that knows healthcare as good as our consultant, if not better. Number 3, no good deed goes unpunished. You try something and it doesn't work. Well, you know, let's keep up with the status quo. Number 4, I can't remember number 4. I know number 5 was we're basically lazy as humans, but I can't remember. I can't remember what number 4 was, Lauren. You may know, but I can't remember. But it was an excellent podcast, and I thought about actually putting that out in one of our newsletters, but I fear I'd lose all of my members if I did that. But it's a really good listen.
Thank you for sharing that. That definitely is a good listen. At this point, we're going to see if there are some questions out there. And Sarah will be taking the virtual questions. So if we have any questions, please step up to the mic. No employer's going to step up now. Well, while we wait for questions, I'm going to ask you to do some work for me. We are working with a particular state, and they're looking at the same thing that Indiana is pricing at a multiple of Medicare. And I read an opinion piece that came out over the weekend by the opposition that said this is wrong for the state to be regulating us, the state to be doing that, because it's taking away our fiduciary role. And I'm really struggling. What would a health system or hospital, how do you define their fiduciary role? So I jumped to not-for-profits. Are they there to serve the community, the public? Oh, great, I'm going to get an answer. Will you help me with this? So I need to get back to the individual state, and I'm thinking, I have no idea how a hospital defines their fiduciary role.
Well, I'm not sure how they define it, but I'll tell you how I define it. If you are a not-for-profit hospital, if you're getting the special tax, no tax benefits, that carries with it a responsibility to the community to provide health care, great health care, quality health care at a reasonable price, not the highest price that you can charge for it and, bank the money and have it offshore and do all this other stuff, but to have it be a reasonable price. And I think it's unconscionable if you, don't do that. And that's me.
I love that answer. Anybody else have a comment? Shawn has opinion on this.
I have an opinion on just about everything. Just want to say I completely agree. And there's a very good foundation based out of DC called the Lown Institute. If you haven't seen them, you should check them out. They do a lot of work on sort of hospital pricing, but particularly a big focus on nonprofit status. And again, as a person who was a hospital lobbyist for a good part of my career, somewhere along the lines, we kind of lost track, or the nonprofit world kind of lost track of what that means, right? And there's a very big difference between some hospitals that actually take this very seriously, some of the public hospitals that I represented, where they are truly doing enormous amounts of uncompensated care, and the significant majority of, I don't even like to use the term nonprofit because it's bullshit, excuse my language.
Tax exempt.
Tax exempt hospitals. Let's ban the word nonprofit when we're related to the hospital system. They're tax exempt for-profit institutions. But we have they've lost the thread, right? And I think Congress has tried to at least nibble around the edges of legislating on this. The hospital lobby is obviously incredibly powerful, but I think it's actually an area that employers and purchasers should be focused on, because as you look at the Lown Institute's information, they've calculated how much money each hospital system saves through their nonprofit status, right? Their tax-exempt status. And the numbers are very large, you can imagine. And actually, if you think about it, they're drawing resources out of the community by not paying taxes back into the community. So there was an expectation that if you're not going to be paying, if you are, I won't pick on IU again. What's another hospital system nearby? Ascension. Oh, God. I think Sutter's bad. If you're Ascension and you're not paying property taxes, and you're not paying income taxes, and you're not paying any of the other taxes that all the rest of the for-profit organizations have to do, you have a responsibility to that community, and that has just been completely lost.
I appreciate this. So you finished my homework assignment for me. I can go back to the state and say that fulfilling their fiduciary role is a role of fulfilling the healthcare needs of the community. Well, that was easy. We have some questions, I think.
Hello, I'm Barry Levitt, a retired person here in Indianapolis. I wonder if our employers forum that's putting on this conference, or Chris's group in Texas, is in touch with Richard Master of Eastern Pennsylvania. He's helped produce 3 different movies about health care and affordable care that he's experienced. Fix It, Healthcare at the Tipping Point is the first one. Big Pharma, Market Failure is the second one. The third one I've forgotten the name of. It's the most recent, concerning hospitals.
No, but I will.
We appreciate that, and I'm sure that the conference leads here will help us get that information out. Thank you. Great comment. Cora.
Shawn, you just mentioned hospital lobby. Can you all give some examples on what are some really good messaging to combat the hospital lobby? I think a lot of the things that we talk about, we talked a lot about employers, and I have an opinion when I'm on the panel to talk about what employers should be doing. But I think the reality is we're combating a really, really powerful lobby. What are some of your advice for employers or other organizations here on how to really combat some of the most common challenges that exist?
So I'll start and be really quick. The National Alliance actually put together I think, really strong document, because I helped write it, called Setting the Record Straight. And it's sort of combating the 10 most common hospital arguments about why they have to price the way they price. It's a really good resource. I actually was not the CEO at the time, but it's a really good resource. It's available on our website. We can make sure everybody has access to it. And I think, honestly, within those 10, most of what you're going to hear back from hospitals is a big one. I'll just flag one really quick, because it's the one I know the best. You will hear every time you talk to a hospital about why they have to charge us 250% of Medicare's, they'll say, well, we're losing an arm and a leg on Medicaid, and we couldn't possibly. If we're losing so much money on Medicaid, we have to charge you more. The short version of that is it's BS. And in fact, most hospitals, between disproportionate share hospital payments, upper payment limit payments, state directed, et cetera, actually they're not necessarily breaking even on Medicaid, but they are actually paid at Medicare rates. And that's according to MACPAC, not me. That's the Medicaid and Chip Payment and Access Commission. And if you ask MedPAC, the Medicare Payment Commission, they will say that a reasonably efficient hospital should be able to break even on Medicare. And we know that many hospitals are actually able to do that. So this idea that we need to pay more because government pays too little is a lie.
I just want to second that report is excellent and will help answer a lot of the specific questions. But I think in the reality, when we're talking about policy in this space, we're not talking about all the hospitals. We're talking about some bad actors, and in some cases, it's just a few named bad actors, and you can see this in some of the legislation you've worked on. And so I guess the high-level takeaway is split the industry. Think about ways where you can help smaller, rural, independent hospitals and really target who you're going after. And then that can help split the lobby. And we've seen in some of the states I was mentioning, the hospital association has to go neutral. They can't come out opposed because some of their members will benefit from it. And so that has been a really powerful tool we've seen some states use.
Thank you. That's a very good point. Yes, Emma.
Hi, folks. Emma Clippinger with New York City's new Office of Healthcare Accountability. I have two questions. One maybe for you, Marilyn, actually, that I've seen some efforts at the state level to standardize the financial information that hospitals are reporting. You know, never underestimate the ingenuity of hospitals. You're reading the footnotes, but could that do anything, especially around community benefit spending? Thoughts?
I totally agree with you. Transparency across the board, transparency into community benefit reporting. And at NASHB, we have developed a template and some models that we wanted to work with states to look at, because the Schedule H, where it's reported, is just very general information. But if you read the instructions, they state that the hospital must keep and maintain all the backup to support those numbers. So our thought was, well, gee, the hospitals have to keep all that backup. That's not going to be hard for them to report. So let's start with transparency. Let's see what it is. You can also read the footnotes within the 990, the Schedule H, and you can see how they determine some of the estimates. But yes, I think that it is fair for a state to ask, and I think providing a template or very detailed really does help, because then you can flesh out the data. Yes, Gloria. Oh, Donna.
I had that bill a couple of years ago. I think it based on your template, actually, and it was not smooth sailing. There was a lot of pushback, and it was probably one of the most pushed back bills that I've ever had. Now, same thing. They have to keep that information. It's just you have to provide it to us, and it should be easy. But boy, there's and which makes me think there's something in there they don't want us to see. So,
I agree totally. Yes, but yes, you can.
Okay.
Yes.
Hello there. Ahmed Mamouche with Handle Health. My question, well, firstly, thank you for raising the employer inertia piece. I think it's very real and is one of our greatest struggles, I think, working in the industry. My question to you is regarding specifically that. To what extent do you think the Consolidated Appropriations Act and the class action lawsuits that are coming out, sometimes against employers, might create the accelerant that we need to see them take a more active role around policy?
It's an interesting comment, actually. I was talking about that with Chris Deacon here at lunch, and maybe it has some opportunity to put the fear of God, if you will, into the employer, but maybe not. I think a good approach is on the business side to make the case why this needs to be raised to a higher level, and because unless it comes down, these HR people, they're just doing what they're told, and they're told not to make waves, but you got to make more than a wave. You got to make a tidal wave, a hurricane here for this to change, and that's only going to come when the C-suite can get a little bit more engaged, and we're trying to crack that nut.
Thank you, Chris. Just a second, we're about out of time. Cynthia?
Yes, thank you. What an excellent panel, and thank you so much for all of your input. Chris, you're right. On the employer side, the C-suite getting involved, CEO, CFO level, and legal, general counsel. And then there's the C-suite on the other side, which I think we call the opposition, or the hospital and the insurance industry and the pharmacy benefit managers. I want to credit the Braun-Sanders bill in the Senate, and again, encourage all of you in supporting this bill, because one of the measures for accountability and integrity in all of this data and getting access to this data is the use of the False Claims Act for the executives of the hospitals and the insurance companies to be held accountable personally, that indeed the prices are true and the billing and the payment data is also true. Much like any CEO or CFO or chairman has to sign for the SEC in a public company that you're held liable if your financial statements are not true. So the long story short is, have the state measures or have the employer organizations looked at simply going forward in state law, that the transparency and all of this reporting be held accountable at the executive level under the False Claims Act, whether it be at a federal level like this Braun-Sanders bill, but also are there measures at the state level and the employer levels to demand that we have accountability?
Thank you, Cynthia. Brad, last question.
Yes, I'm Brad Brockbank with the Peterson Center on Healthcare. Just a quick comment about a resource that came out of a project that we helped fund called the Peterson Milbank Program. One of the resources that's available through that program is called a Guide to Hospital Financial Analysis. And it's a part of a suite of resources that have been made available primarily to state folks. But I think it's safe to say that the information contained in that report is maybe not quite as good as training new Marilyns, but might be close. And it certainly is a step in the right direction.
Thank you, Brad. Sarah.
Yes. Okay. So I have two questions, but we can be quick. So the first one is, what is there an opportunity to incentivize independent physicians to leave hospital systems? Maybe not quick.
Well, we had in 1004 last year, we offered for, and it was for primary care physicians, but if they established a new independent practice, they got a tax credit of $20,000 a year for 3 years, just trying to give some kind of incentive. So that's something we did in Indiana. And we haven't had time to see whether that's effective. I'm really interested to see from the Department of Revenue how people are taking them up on it. But that's one thing.
Great, that's very innovative. Any other suggestions? I really do like that. We see the other side where the hospital systems want those physicians because then they really maximize their 340B profits and their referrals to begin with.
We're trying to create a direct contracting model, capitated, but to get primary care physicians to leave, you got to pay them like twice what they're being paid right now. Or they've got to be, maybe not twice, but you've got to invest more in primary care. We saw the shortages that are predicted here. We've got to invest more in primary care so that they don't have the only option of just going with the hospital system.
Marilyn,
Great.
then the non-competes.
Oh, yeah, well, yes, let's talk about the non-competes. Federal Trade Commission. Sarah.
Yes. Okay, one last one. Can you please comment on the effect of private equity investments of billions of dollars buying up ER doctor groups, anesthesia groups, ortho groups, and net effect of higher PSRP and fewer negotiated contracts with the commercial insurance plans?
We're going to ask Chris Whaley on this one because this is an area that he is studying at Brown University.
Yeah, so we know that this is the new wave of consolidation. And just to be brief, when a PE firm acquires a practice or provider, it maybe not surprisingly raises prices, but not nearly the same level as when a hospital acquires the same provider. And so I think there's importance to think about how, not just the effect of PE, but how does that fit into consolidation writ large?
Thank you. Shawn, did you have a comment on this?
Yeah, just real quick. I mean, I'm glad that Chris is studying this. I would say, if you have enough money to invest in private equity, I don't, but I've talked to people who do. What they promise is, it's really outsized profits, right? Like that's the whole point of being in private equity. So they're constantly looking for where's the market failure and where can I make the most money. So like while we were doing surprise billing, air ambulance was the place because you could make a boatload of money on air ambulance. So consistently, if you see PE flowing into a space, it's because there's a market failure there. Just inherently, that's why they go there. The thing I would say really quick is this is why ownership transparency is so critical. We were talking about this over lunch. if we are really going to understand, the full market dynamics, you need to know who owns whom, because otherwise you can't really get a sense of where the market power lies.
Good point. Yes. Organizational transparency. Well, I think that ends our panel and ready for the next one. And I thank you. Great ideas, and you did my homework assignment for me.